The lungs have two circulations. We have described briefly the pulmonary arteries and the pulmonary veins. Now we're going to show you the second circulation, the bronchial arteries and the bronchial veins. In this cadaver section, we isolated the descending aorta and ligated its branches except the bronchial arteries. Note that there are some small vessels which arise from the descending aorta, and they branch in the mediastinum and eventually continue towards the hyla and parallel the bronchi and the pulmonary arteries. Note that they are very small and they represent the bronchial arteries. If we inject a blue dye, as we did in this isolated segment of the descending aorta, and open the airway, we can see the blue stained mucosa of the distal trachea, which is a picture to your left. In the middle, we can see that the blue is noted following the airway. And in the right image, we can see a reticular pattern in the distal airway that represents all the distribution of the bronchial artery. In this close-up of the distal airway, we see in blue the dye that stains the distal airway. And note that it stops 1 to several centimeters from the cortex of the lung. This means that the blood that enters the lung via the bronchial arteries does not perfuse the periphery of the lung, and it perfuses the tracheobronchial tree up to very small branches of the bronchi. This is a cast corrosion showing the dorsal view of the tracheal bifurcation, which is seen in white. The purple vessel represents the descending aorta. And note that we see a number of very small arterial branches just in the subcarinal region. And note that we have small branches of the bronchial arteries following the tracheobronchial tree. This is to show that before the bronchial arteries go into the lungs, they supply branches to mediastinal structures. These are photographs of the mediastinal structures. To your left, note blue stained lymph nodes, which are also seen in the top right image. This means that the bronchial arteries supply the lymph nodes of the mediastinum. The bottom right shows the vasa vasorum of the aorta, which comes from the systemic arteries, which arise from the proximal descending aorta. So that is another anatomical structure that is supplied by these systemic arteries. The parietal pericardium to your left shows blue vessels, which come from the injection of the blue dye in the descending aorta. And to your right, we see a close-up of the mediastinal pleura, which is also supplied by the bronchomediastinal artery. To your left, we see blue vessels going from the aorta to the esophagus. So the esophagus is also supplied by the bronchomediastinal arteries. And to your right is the esophagus opened, where we can see the esophagogastric junction, and above it we can see the stained mucosa, which means that the bronchomediastinal arteries through the esophageal arteries supply nourishment to the thoracic esophagus. This is a diagram from Caldwell's work, which shows the number and the distribution of the bronchial arteries. Sometimes there are several bronchial arteries to the right lung, and several can supply the left lung. They usually arise from the proximal descending aorta. And some of the bronchial arteries share a common trunk, and on the right side it is quite common to see that the first right aortic intercostal gives off the first right bronchial artery, which may be the only artery supplying the right This is a diagram of the bronchial arteries. Note the right upper bronchial arteries comes from a trunk which gives off the first aortic intercostal, and this is called the intercostal bronchial trunk. Note that the right lower bronchial arteries comes from a single vessel which also gives off arteries to the left lung. Most of the time, the bronchial arteries to the left lung arise independently from the ventrolateral aspect of the descending aorta. And the way to search for these vessels is to go from the arch of the aorta to the level where the left main bronchus crosses the descending aorta. This is a selective bronchial arteriogram, probably the first one ever done in the world, where we injected the intercostal bronchial trunk. Note that there is a vessel that is directed cephalad and eventually parallels the lower margin of a rib. And there is another vessel that goes towards the hilus of the right lung. Because this is a procedure done under local anesthesia, it is not possible to inject large amounts of contrast. So therefore, we usually fill the bronchial arteries that supply mediastinal structures and those that supply the medial third of the lung. This is another normal left bronchial arteriographic examination where individual bronchial arteries were injected. And this is to show again that they usually arise independently from the proximal descending aorta. In our first series of bronchial arteriograms, we found vessels that came off from the arch of the aorta and all the way down to the mid-thoracic aorta. The site of origin and frequency of these vessels are illustrated in this diagram. This is a lung scan, frontal view, following the injection of macroaggregates of radioiodinated albumin, which we call the MARIA, macroaggregates of radioiodinated albumin. And note that the activity is seen in the central portion of the lungs, in the perihilar region, and obviously also in the mediastinum. This is to show that the blood distribution of normal bronchial arteries is primarily to the mediastinum and to the root of the two lungs. This is a close-up of a distal right pulmonary artery, which shows a yellow vessel that represents a branch of this pulmonary artery following the same trajectory. Now we are going to see in the next image how these small arteries can connect with the bronchial arteries. In this image, we see the bronchial artery in red and the pulmonary arteries in yellow. Note anastomosis by inosculation, which means telescoping between a bronchial artery and the pulmonary artery. The bronchial artery supplies the blood for the tracheobronchial tree and can connect with branches of the pulmonary artery at a pre-capillary level. So there is theoretically a left to right shunt at the pre-capillary level. However, the magnitude of flow in the pulmonary artery makes this shunt hemodynamically and physiologically insignificant when there is a small bronchial arterial flow to the lungs. This diagram, we can see what may happen when there is increased bronchial arterial flow to the lung. Because of a pressure gradient between the bronchial arteries and the pulmonary arteries, the left to right shunt can fill the pulmonary artery and provoke a retrograde flow in this vessel. That's why you can see to your left a normal situation, to your right the arterialized pulmonary artery. In other words, blood goes from the bronchial arteries to the pulmonary arteries due to the fact that the capillary bed of the lungs has a limited capacity of blood volume. Therefore, blood may penetrate the pulmonary arteries and cause a hemodynamic obstruction and a retrograde flow in distal branches of the pulmonary artery. Congenital and acquired pulmonary conditions may expand the bronchial arterial tree. And in this case of saccular bronchiectasis, which you can see at the bottom right of the slide, we note that in the surface of the bronchi, there are markedly dilated bronchial arteries. Here we can see to the left the same specimen we previously described, and to the right evidence of bronchopulmonary anastomosis. Note the large bronchial artery, which gives off a side branch which runs above a bronchus and empties into a pulmonary artery. So this is a precapillary bronchopulmonary anastomosis that is commonly seen with inflammatory pulmonary conditions, particularly suppuration and bronchiectasis. In this subtraction digital angiogram, we note a markedly enlarged right bronchial artery, which fills a right lower pulmonary artery. Note that the filling occurs at a precapillary level, and this patient had bronchiectasis that produced increased bronchial circulation. This patient with bibasilar bronchiectasis showed that the bronchogram was about the same in appearance on the right as well on the left side. But the bronchial arteriogram revealed larger bronchial arteries to the right lower lobe than to the left lower lobe. In this selective right bronchial arteriographic examination, note the bronchial hypervascularity and the filling of the pulmonary artery. When one observes this phenomena by fluoroscoping the bronchial angiographic examination, we can see a to and fro motion of the opaque column in the pulmonary artery. In other words, it fills distally first, contrast moves up the pulmonary artery, and then with another systole, the contrast moves towards the periphery of the lung. This produces a to and fro motion of the radiopaque column. And this is an in vivo demonstration of bronchopulmonary anastomosis with filling of the pulmonary artery from the bronchial arteries and eventually dissipation of the contrast as it goes into the pulmonary capillaries and eventually into the pulmonary. Why would a patient with chronic lung disease develop left ventricular enlargement and cardiac decompensation? Well, the chronic lung disease may lead to pulmonary hypertension, but the possibilities are the following when left ventricular failure occurs in the presence of chronic lung disease. One, the patient may have ischemic cardiomyopathy, that is, there may be unrelated pathology of the coronary arteries, or due to the chronic hypoxia, the left ventricle may become involved and failure will ensue. The other possibility is that the patient may have other cardiac conditions such as papillary muscle dysfunction, mitral regurgitation, aortic regurgitation, etc. But in the absence of coronary artery disease and in the absence of valvular disease, the left ventricular decompensation may be the result of extensive bronchopulmonary anastomosis. In other words, the patient has a left to right shunt from extensive communication of the bronchial arteries with the pulmonary arteries, and that leads to a left to right shunt, the chronicity of which and the magnitude of this shunt may throw into failure the left ventricle. This patient had chronic lung disease and extensive bronchiectasis, and 6 years later, the picture to your right shows cardiomegaly and left ventricular failure. The only explanation was extensive bronchopulmonary anastomosis and a large chronic left to right shunt of arterialized blood from the bronchial arteries going into the pulmonary arteries, from there to the pulmonary veins, left atrium, left ventricle, back to the aorta, from the aorta to the lungs, from the bronchial arteries, and back to the left side of the heart. So that is the mechanism, one of the mechanisms of left ventricular failure in the presence of chronic lung disease. The pulmonary arteries have an internal and an external elastic lamina, as seen in this slide. The bronchial arteries have only an internal elastic lamina. That's why when pathologists look at cross-sections of these vessels in the lung, enlarged the bronchial arteries can be readily distinguished from pulmonary arteries. Here we injected the bronchial veins. Note that they are small blue channels intimately related to the tracheobronchial tree. In this cast corrosion preparation, we note in the close-up the large pulmonary arteries, the white tracheobronchial tree, and the black vessels represent the bronchial arteries. The green vessels represent the bronchial veins. The blood supply to the tracheobronchial tree is drained primarily by the bronchial veins. And the bronchial veins end in the azygos system.